चालेल ना. ओके. बरं.
अभी तक चालू नहीं हुआ शुरू। मीटिंग है पापा।
नहीं, ऐसा भी तुम सुन सकते, अगर तुमको कान का मांगता है तो लगा के दे दो।
हेलो डॉक्टर रूपा।
बोटवा कहाँ गवा बोटवा?
हेलो डॉक्टर रूपा।
ऐसा भी तुम सुन सकते, अगर तुमको कान
Yes,
का मांगता
yes,
है तो लगा
Dr.
के
Jyoti. We'll wait for
म्यूट
2-3 minutes
करण्याचं
more.
ऍक्सेस देणे.
परत आता हो हो yes.
को होस्ट कर कोणाला तरी,
हो
जयश्री
हो
किंवा
हो दोघा तिघांना करते.
युट्यूब लाईव्ह झालंय, आपण सुरू करू शकतो. वाजलेत ते.
We'll wait for 2-3 minutes. YouTubeची लिंक पाठवलेली आहे ग्रुपवरती. जर गरज लागली तर लोक त्याच्यामध्ये बट विल वेट फॉर 2-3 मिनिट्स ज्योती. कारण नेहमीपेक्षा आपण नेहमी जनरली 3:30 ला घेतो ना, फक्त 3चा टाइम ठेवलाय. टू वेट फॉर 2-3 मिनिट्स.
ओके.
पुजारी सर जॉईन नाही झाले ना सर?
झालेले आहेत सर. गुड आफ्टरनून पुजारी सर. एकदा स्क्रीन शेअर करण्याचं बघून घेऊयात सर. अँड
Yeah,
we'll wait for 2-3 minutes more and then we'll start. Is that okay?
yeah.
Yeah. Sorry, एक second sir. I'll just go.
दिसतंय आता?
अजून या नाव एकदा प्रेझेंटेशन मोड वरती एकदा.
हे प्रेझेंटेशन मोडवरच आहे.
इट वॉज सीन लाईक स्लाइड्स याच्यामध्ये दिसत होतं.
आता पूर्ण स्क्रीन दिसतोय ना?
हा येस नाव इट इज. येस सर. येस. We'll just wait for 1 more minute and we'll start. 3 or 5 we'll start.
स्टॉप शेअर करू का आता?
आणि participants पैकी we have shared the YouTube link as well here on the chat also. So in case any of your friends or colleagues who are unable to join, please ask them to join on YouTube, please.
टेबल लाव.
Hello. Yes. Dr. Jayashree, you will have to share the YouTube link even on our core group and other volunteers member ka group. But
Yes,
Huh?
yes, I'm sharing it
because
right.
people are calling and asking
Yes,
for
yes.
that.
Yeah,
So yes, and Dr. Prakash Mahajan sir, should we start?
Yeah, I think we'll start.
So yes. So good afternoon all. I, Dr. Rupa Agarwal, Secretary of MCF, invites you all for this beautiful and knowledgeable lecture on the chikungunya related viral infection that we all are facing in today's medical practice. To begin with, about Mukta Charitable Foundation, as you all know, that Mukta has been serving the society right from starting of HIV related telephonic counseling from 2005, and then started towards addiction, slowly towards gender and sexual health in schools, and finally now, nevertheless, the mental health related helpline that is run by Mukta. Along with this, we are also working in the field of first aid, where physical first aid and mental first aid या दोन्ही प्रकारच्या फर्स्ट एड वरती मुक्ताचं काम चालतं. इफ यू with any of your known institutes wants to take any learning on any of these topics, may it be addiction, may it be sexual reproductive health, may it be first aid of physical or mental health level, so you can contact any of the volunteer of MCF. Our name, number, website address will be given in the chat box. And with this brief information, I will also like to let you all know that Mukta runs a medico-legal forum, which has 206 doctors on its panel. And this forum helps us to keep our practice as ethical, rational, and legally safe while we are practicing. Whatever legal problems we have in our practice, we all can make use of proper guidance from our experts like Dr. Jayant Naurange, Dr. Utture sir, Dr. Alka Kute. Like this, we have 10 experts from this subject with whom we can take answers for our queries and make sure that our learnings are up to the mark, so that our practice is really official, really medico-legal practice. And with this, let us come to our today's presentation, which is going to be spoken by Dr. Sanjay Pujari sir. Dr. Pujari, we all know him very well with our experience from HIV to till date. And Dr. Sanjay Pujari, to introduce him formally, he is Director of Institute of Infectious Disease in Pune. He is Consultant HIV Medicine Infectious Disease attached to Pune Hospital and Research Center. He is Therapeutic, especially Site PI for Therapeutic Research Education in AIDS Treatment Asia, Fellow Infectious Disease Society of America, PubMed Indexed Publications under his name 117 in number. National International Faculty, including annual European AIDS Clinical Society for HIV Summer School from 2015 and till current date. He is participant of WHO's consultants where Advanced HIV Disease and FDC for treatment of AIDS, TB, and malaria. He is member of expert group on future pandemic preparedness, Niti Aayog India, ICMR National Task Force for COVID-19. He has conceived and produced award-winning short film, You is Equal to Me. beyond this, there are many other things to be spoken about, Dr. Sanjay Pujari. But here, without wasting much time, I will invite Pujari sir to deliver his talk. Dr. Sanjay Pujari sir, please.
Yeah, thank you for the invitation. Let me start screening. Okay, are the slides visible?
Yes. Yes, sir.
Okay. So thank you for the invitation again. It's good to be in this group. Unfortunately, I'm a little ill with sore throat, so please pardon my voice. So Chikungunya, as we all know, has been causing an explosive outbreak currently, not only in our setups, but also across various states in India. And we will try to deal with this in understanding the basics of Chikungunya, followed by clinical features. I'll focus mostly on primary healthcare. Then we will talk about intricacies of diagnosis of Chikungunya, a few points on management, and finally summarize prevention tools for Chikungunya. So as you can see here, the global distribution of Chikungunya, you can see here predominantly Latin America, Africa, as well as South and Southeast Asia. And this is predominantly the tropical climates, where you see the prevalence very high of the Aedes species of mosquitoes, both Aedes aegypti as well as Aedes albopicus, which are basically the major vectors of transmission of Chikungunya. If you look at the spread of Chikungunya over the years, and this is something which is being projected up to 2050. You can see that this blue bar is where the prevalence of Aedes aegypti is going to be there, again predominantly in the southern hemisphere. But as you can see here in Europe as well, in temperate regions, Aedes albopicus is going to come up because of its ability to adapt to colder temperatures. Well, these are the temperatures associated with the reasonably high humidity as well as a high temperature where aegypti comes in. Just to remember that there are distinct lineages of the virus, and the lineages vary according to the geographic regions. So, for example, in Southeast Asia, it's predominantly the Indian Ocean lineage, while in Africa, you have the West African as well as the East Central South African lineages, which are common. And in Latin America, again, you have the Asian lineage, which is more common. How does this lineages differ? It differs in terms of the mutations in the envelope protein, and this has twofold implications. One is its ability to infect different species of mosquitoes, and at the same time increasing replication in mosquitoes so that these are efficiently transmitted, as well as the receptor binding in the host tissue, like for example in humans, that also is mediated by the two important mutations of the Indian Ocean lineage. Currently, we find that the current outbreak in India is no different than the previous outbreaks of the Indian Ocean lineage. So we don't see a different virus or an additional mutation which is causing this outbreak. If you look at the evolution of Chikungunya in India, there was major outbreaks happening in these states in India in the 1970s. And for some reason, for about 35 years, there was no outbreak of Chikungunya in India. And then in 2005, we had a major outbreak, and subsequently in 2016 in the southern and the central states also. So you should remember that, we don't see Chikungunya outbreaks happening every year. And the reason for that perhaps is basically climate change, year to year changes, but most importantly, perhaps immunity, the herd immunity which is there. And fortunately, in Chikungunya, herd immunity is very, very robust. And most importantly, also, that it is believed that once you get infected with Chikungunya, you may have a lifelong immunity for Chikungunya. And that is the reason you have a gap of about 25-30 years between major outbreaks. And that is as new population comes in, which are naive immunologically to the exposure to chikungunya, they get infected, and then you have the higher, as well as elderly populations. When immunity starts waning with age or immunosenescence, you will have this population also getting infected, causing outbreaks. So remember that chikungunya outbreaks do not happen every year, but major outbreaks. But you see epidemics happening because it's an endemic disease within the epidemics across the states. And this is some of the data from India, as you can see here. These are confirmed reported chikungunya cases from 2018 to 2024. And if you can see here, it's just 12,000. So obviously, this is under-reporting to the government. So we are obviously seeing more cases than 2024 is up to February 2024. In terms of transmission, we know that it is transmitted by the bite of the Anopheles mosquitoes, and there are two cycles: the sylvatic cycle and the urban cycle. Sylvatic cycle is where it happens in forests, where non-human primates are susceptible for getting chikungunya, and this bite, and these are wild mosquitoes. But many a times these wild mosquitoes come back into the with the for deforestation, etc., into the human population, and then they start causing an urban cycle, and in between we have a rural cycle as well. So in Asia or in India, for example, it's the urban cycle which keeps the chikungunya epidemic or quite endemic, as well as recirculating every year based on the climate situation. In terms of transmission of chikungunya, obviously, it's very clear that it's majority of the times mosquito bites by the female Anopheles mosquito. But then there is also mother-to-child transmission of chikungunya, but this predominantly happens when the mother is infected during delivery. So 2 days or 5 days after delivery, where there is peak viremia, the mother can transmit it to the baby through transplacental ruptures. And this can lead to chikungunya in neonates, which is quite different from chikungunya in adults. But this is important to remember, because in an epidemic situation, you may have pregnant ladies closer to deliveries getting infected with chikungunya, and close monitoring of the baby born is needed to manage the baby with chikungunya. And finally, very rarely you may have transmission through blood products or transplantation. There are reports of corneal transplantation leading to transmission of the chikungunya virus. In terms of pathogenesis, it's what happens predominantly once the mosquito bites. It not only injects the viruses, but most importantly, it injects its saliva. And it is believed that the saliva of the mosquito modulates the immune response and the pathogenicity. So, for example, if you inject the chikungunya virus through needles, it doesn't really cause disease. It has to be combined with the saliva of the mosquito. Some immune properties of the saliva of the mosquito leads to immune modulation and higher replication of the virus once it's inoculated into the skin. In the skin, various cells are getting infected. Directly replication happens. And this is believed to be causing the skin rash associated with chikungunya. Subsequently, there is these cells which traffic towards the regional lymph nodes and through the blood vessels, and there is high levels of replication, almost 10 raised to 11 to 10 raised to 10 copies per ml of replication happens. And then this goes into lymph nodes, and from there it goes to practically every organ system in the body. And because of the high replication rate, with predominant focus on the joint, as well as the bone tissues and the muscle tissues, musculoskeletal system. But of course, it can go to every organ. So predominantly, as you see here from the immunopathology, you can explain why you see certain clinical features in acute chikungunya. This I will not go into the details, but what is important to understand is we all know that many people get infected with chikungunya virus. Some recover, some do not recover, some have chronic illnesses. So what determines this? So as I told you before, there is very high levels of peak viremia as shown in the red graph here, which is associated with the viremia is associated with the classic symptoms of fever, musculoskeletal and rash. But then there is an immune response which tries to clear the virus, and it is more efficiently clearing the virus, causing self-limiting disease. But sometimes you can have cytokine storm, and this cytokine storm, if you all remember, came from COVID. This same thing can happen in chikungunya, and that can be associated with severe clinical manifestations of chikungunya, and this is because of a dysregulated immune response. And once you have the viremia going down, you start producing antibodies, both IgM and IgG, because of B cell. And this is something which predominantly gives the IgG mostly a lifelong immunity against reinfection with the chikungunya virus. So now let us come to the clinical features of chikungunya. And clinical features of chikungunya is classically divided into 3 phases. You have the acute phase of chikungunya, which is defined up to 21 days post-infection. Between 21 days to 3 months, you have post-acute phase. And finally, beyond 3 months, you have a chronic phase associated with chikungunya disease. Obviously, the clinical features will differ between these 3 phases. But most commonly, what we see in the acute phase is a classic triad of chikungunya, which is fever, arthralgia, arthritis, or rash. And then you may have a small proportion of individuals, usually less than 1%, who may have severe manifestations of the disease, perhaps associated with the cytokine storm that I showed you before. And this can involve various organ systems, may be directly associated with high levels of virus, or because of the immune response and the cytokine storm associated with the virus. It's not clear really what drives these severe complications. So we do not obviously then know how to efficiently manage these severe complications. In the post-acute phase, you have fever disappearing after day 7 to day 10. But then you may have lingering arthritis, tenosynovitis, bursitis, soft tissue edema, and asthenia, or fatigue associated with this, which many times also is self-limiting. And most individuals would recover from this as well. So almost after that, it has been determined that almost 50% of individuals will develop or progress into chronic phase. And this chronic phase is predominantly driven by arthritis and manifestations of joint and musculoskeletal disease. So you have 2 forms of that. You have the P-CHIK CIR, and we have the P-CHIK MSD, the musculoskeletal disease, and the rheumatic kind of a presentation of joint disease. We'll go into the details of each of these steps a little later. I don't need to tell you, all in primary care, you see various symptoms of acute chikungunya. Fever is a major symptom. It usually is high grade, but in this epidemic, we are seeing some patients coming to us with low grade fever. Joint pains, the classic feature of joint pains is multiple symmetrical joints involved, usually distal as well as proximal. Sometimes you may have more than 5 different kind of joint systems involved. So that is very classical of chikungunya. Nothing else in that sense, other infections would give you more than 5 joint involvement. So fever, joint pain, and a rash, which is usually a morbilliform rash, which is usually non-pruritic. If it is pruritic, it is more likely to be Zika. And then you have other symptoms like headache. In headache, it is usually a periorbital headache, while classically in dengue, you will have retroorbital headache. So that is one clinical marker which may try to help you between differentiating between chikungunya and dengue. And then you have GI symptoms, chills, etc. So this is nothing which is very great. Most of us see acute chikungunya with these kind of presentations. And this is, as you see, the various joints involved in acute chikungunya. Usually these are extremely painful. There may be swelling associated with it. Sometimes there is only arthralgia. Sometimes there is arthritis inflammation as well associated with this. So nothing really great. All of us see this. But then very few patients develop a range of extra articular manifestations. And this is a study from Brazil, where majority of chikungunya studies, well-conducted studies, are published from. And as you can see here, almost all organ systems are involved. You can have eye involvement apart from the retroorbital or the periorbital pain. You may have uveitis, keratitis, optic neuritis as well, associated with the chikungunya. With the renal manifestation, the commonest would be an acute kidney injury because of dehydration associated with the initial fever. But apart from that, you may have interstitial nephritis, glomerular nephritis, etc. GI disturbance in terms of diarrhea, vomiting. You may have hepatosplenomegaly and hepatosplenomegaly, and also systemically you may have lymphadenopathy associated with chikungunya, which is not seen in dengue or Zika. In respiratory manifestation, you'll see pneumonia and ARDS, and we recently saw one patient with chikungunya pneumonia. The commonest extra-articular involvement is the brain, and that is usually presenting as encephalitis. You may have myelitis, you may have a post-chikungunya Guillain-Barré syndrome, or you may have a post-chikungunya acute disseminated encephalomyelitis. Often we forget mental health in these individuals, so depression, psychosis, and confusion is also been reported as psychiatric manifestations associated with chikungunya. In cardiac, you have myocarditis, arrhythmias, pericarditis, which can present. You may have a pericardial effusion as well. Skin manifestations, apart from the rash that we see, you have various other very rare skin manifestations. Fortunately, these are all self-limiting. And finally, the classical hematological features is lymphopenia, which is very common in chikungunya, which differentiates it from the other two viruses. You may have very rarely bleeding problems, but bleeding problems, as we all know, is more common with dengue. So who are these people who develop these complications? Now, usually you will see it in elderly population or extremes of age, either neonates or very young children, or you have extremes of population aged, geriatric age, more than 60 years. People who have comorbidities like hypertension, diabetes, hypothyroid, etc. Pregnancy, of course, can also be associated. Underlying pulmonary disease like COPD or asthma can also be associated with this. So if you can really correlate this is quite similar to the COVID-19. The severe COVID-19 happened precisely in the same population that we are talking about. And the same is perhaps true for chikungunya. If you have co-infections with other tropical infections, whether it's dengue, Zika, and in Latin America, almost 30% of individuals in an epidemic scenario are co-infected with chikungunya, dengue, or chikungunya Zika. We don't know whether this leads to higher risk of complications, but it is widely believed that these individuals may develop multiple complications and variable clinical features associated with it. So these are the population which you should monitor for development of complications. Some examples, of course, these are not what we have seen, but I've picked it up from Indian literature. You can see erythema in the ear pinna, and this is called as the million sign. You may have striae getting a rash here. So this is a striae-associated rash. And this is the classic chick sign, which is basically blackish discoloration of the nose, which is seen in some patients. Fortunately, all of these little different lesions are cutaneous lesions are self-limiting and don't need specific treatment. They recover on their own. Neurological manifestations in the acute phase is different from in the later post-acute or chronic phase. In the acute phase, you have encephalitis, and you see the MRI picture here. You can see punctate hyperintense lesions which are periventricular, which are involving the matter. And this is very, very classical of chikungunya. It is not seen in any other tropical encephalitis. In the spinal cord, when you have myelitis, if you can see here, it's a little unclear, but this is called as a clock dial. You can see this is a clock, and you have multiple hyperpigmented whitish lesions at the periphery of the spinal cord. So this is also very classical for chikungunya myelitis. And then you have a range of other, you have cranial neuropathies, facial, optic neuritis, you may present with stroke, but these are extremely rare. And this is less than 0.3%, etc. But what happens is when you have a bigger outbreak, then you start seeing these complications and you wonder whether this is more common than in the general population, but in the population with chikungunya. But this is not really true. You have higher numbers of patients, and that is the reason why you are seeing some of these severe manifestations. In the post-acute phase or in the chronic, it's very, very unlikely to develop any neurological complications in the chronic phase. But in the post-acute phase, starting from 1 week onwards to up to 3 weeks or even up to a month, you may have GBS, which is there, and we have seen GBS associated with the infection. You may have optic neuritis, retrobulbar neuritis, myelitis, and acute disseminated encephalomyelitis. So these are some of the presentations associated with the post-acute phase of chikungunya. Pulmonary manifestations, you may see pneumonia, and pneumonia is something which we have seen in a young boy during this epidemic, who presented with bilateral consolidation with ground glass opacities that can lead to ARDS. Fortunately, that was again self-limiting, and the boy recovered on his own. And then you have diffuse alveolar hemorrhage as well, which may be there. The post-acute phase, as we already show, is just lingering of the joint involvement. But now you have something called as beyond 3 months, a chronic chikungunya disease. And this is often labeled as CCD or chronic chikungunya disease. Usually it is driven by rheumatic kind of joint involvement. And this also can involve the larger joints. But most importantly, there are 3 varieties of chikungunya rheumatism. One is the RA variety, and if you know about the ARA-UCLAR RA criteria, many of these patients satisfy the ARA-UCLAR RA criteria. So it's very difficult to distinguish between rheumatoid arthritis or post-chikungunya chronic arthritis. So in your practice, going ahead from now, if somebody comes to you with chronic arthritis, make sure you ask history of chikungunya, and that is something, because this can mimic all your other kinds of arthritis. So get it into your history to find out whether a patient has had chikungunya history, his illness in the past. We have the spondyloarthritic variety, which satisfies the ASAS criteria for spondyloarthritis, and then you have an undifferentiated wide varieties of arthritis. If you look at the distribution of joint involvement in acute versus chronic, and these are some of the clues by which you can differentiate. One is, of course, the larger joints are not involved in chronic chikungunya, while they can be involved in chikungunya. It's usually the distal peripheral joints, the wrist and the phalangeal and the ankle and the feet joints. So this again mimics, as you know, the rheumatoid arthritis. There may be a lot of morning stiffness associated with the joint involvement, and it can be extremely disabling, affecting the quality of life and working of the patient. So who develop this chronic chikungunya disease? Usually elderly populations, female gender, those with comorbidities, those who had severe arthritis in the acute phase, and those who had very high viral load levels during the acute phase of the illness. So these are some of the risk factors associated with CCD. So you need to just keep an eye on these populations for progressing into CCD. Now let us come down to diagnosis. The most important thing in diagnosis is a mixture of different diseases which are coming together, and it's very, very challenging to differentiate between dengue, chikungunya, and Zika. These are simultaneously circulating in the population, and then it becomes very difficult for us in practice in primary healthcare to find out who is having what. At the same time, as I already told, patients may have a combination of 2 infections also. So it's very, very difficult. But some of the clues I will show you, and this is from the Pan American Health Organization guidelines. If there is thrombocytopenia, progressive increase in hematocrit and leukopenia, it is more likely to be dengue. If it is arthralgias, it is more likely to be chikungunya. And if it is pruritus, along with the rash, it's more likely to be Zika. So these are just rule of thumb in terms of differentiating between these 3 illnesses at the clinical level in primary care. But then there can be various other things which can help you differentiate between chikungunya and dengue. So as I told you, joint pains predominates chikungunya. It's not very common in dengue. while headache and bleeding manifestations predominate in dengue. Fever is usually abrupt onset, lasting for 3 to 5 days in chikungunya, while it lasts 5 to 7 days in dengue, and it's not very abrupt onset. Rash usually appears in chikungunya on day 2 or 3, but appears between day 5 or 7 in dengue. As I told you, arthralgia is more frequent. Musculoskeletal component arthralgia is more predominant in chikungunya. Muscle pain is more predominant in dengue, and bleeding manifestations are more common in dengue. Organ involvement is very rare in chikungunya, but you can see it very common in dengue. Hypovolemic shock obviously is not there or rare in chikungunya, but is frequent in severe dengue. We all know because of third space loss and the dengue shock. Leukopenia is infrequent in chikungunya, common in dengue. Thrombocytopenia common in dengue, and hematocrit is high. So these are some of the markers which can help you with the DD between chikungunya and dengue when a patient walks into your clinic with these varied manifestations. So with that, you will have viremia, which usually coming in the initial 5 to 7 days, and then you start producing antibodies, IgM and IgG, which you want to use for laboratory diagnosis. So if you look at these markers, so initially from day 0 to day 4 to 7, you will have high levels of viral replication, and here you can use the RT-PCR for diagnosis of chikungunya. After day 4 to 7, you start producing IgM antibodies, and then subsequently IgG antibodies, and that can be detected by serology by an ELISA. So remember, the timing of presentation of the patient will make you decide what test to order for diagnosing of chikungunya. Initially, up to a week, you should use an RT-PCR. After a week, rule of thumb, you should use an ELISA, especially IgM, for diagnosing chikungunya. Now, I already told you that it's very difficult to differentiate between various circulating tropical infections. So what we use is a multiplex PCR, which is also called as a fever panel, where you will see the 4 viruses which are there, the parasite malaria, as well as Leptospira, Salmonella, and Rickettsia. And this is one of our patients you can see here who has chikungunya. But many a times you may have somebody who is having both Zika and chikungunya. So try to use multiplex PCR rather than focusing when there are multiple circulating tropical infections which are causing problems, and very difficult to choose out who's having what. In terms of interpretation, very easy. IgM only positive is a recent infection. IgG only positive is a past infection. And this is where you will use it in chronic chikungunya disease or CCD, where you do IgG to find out whether the arthritis is associated with previous chikungunya. If they have both, it can be a recent or past. And obviously, if they both are negative, it can be a negative. But if you are clinically suspecting that the patient is having chikungunya, please repeat the test after 5 to 10 days, because there is quite a variability in appearance of these antibodies, which can differ between patient to patient. Right now in the market, we also have beds, things which you can perform in the clinic. These are rapid serology tests, rapid card tests, for example. We don't know the performance of this test. We don't really use it in our practice right now. But this is something which, if it comes positive, you may be able to, with the right clinical context, have a good positive predictive value. So these are some of the methods which are available, which can be done very rapidly, and the results can be got early. We don't know, of course, the performance of these tests in a wider epidemic. So this is what we use, a practical approach. So in a suspected chikungunya case, after initially up to day 7, you will use a molecular test, detection of viral RNA. If it is positive, diagnosis is confirmed. If it is negative, you can consider an alternative diagnosis or go for IgM testing after a few days. If IgM antibodies are positive after day 5, diagnosis is confirmed. If negative, consider alternative diagnosis or repeat if clinically you feel that chikungunya is still not over. Let us come down to management, and of course, management will differ according to the phase. So in the acute phase, we know that there are no specific antivirals. It's usually supportive care. So use analgesics, antipyretics, hydration, and rest. Analgesics should be used in a stepwise fashion, and we will talk about it. NSAIDs are usually avoided if you are not very clear whether it's chikungunya or dengue for two reasons. Because NSAIDs are associated with increased bleeding in dengue, and NSAIDs may interfere with the immune response in chikungunya, delaying the clearance of the virus. Steroids are not recommended. IVIG is not recommended. But maybe for severe disease with the cytokine storm kind of a picture, maybe you can use this. But this is again, there is not very, very great evidence for this. There are only anecdotal experiences of using this. And please remember, no antibiotics for managing chikungunya. So this is the analgesia ladder, which is proposed by WHO as well as the National Vector Control Organization in their guidelines. So you start with paracetamol. This is step 1. If paracetamol is not effective or the patient is still continuing to have pain, you can add tramadol to this along with along with paracetamol. And finally, very rarely, if a patient is not really controlled with this too, you can use opioids like morphine, though we have never used morphine in this context. So what we do is a very practical approach. We start with paracetamol 500 milligram to 1 gram TID. If there is an inadequate response, to add an NSAIDs after preferably ruling out dengue. Watch for 1 to 2 weeks. If the patient is not responding, switch to another NSAID. So if you started with, for example, naproxen, you switch to ibuprofen or diclofenac. And then finally, very rarely, we have never done this, but you can use opioid analgesics. This is the management of acute and post-acute phase. Never forget ancillary interventions. Rest, you have to recommend to your patient. Adequate hydration, cold compresses of the arthritis. Around recovery time, you should start telling your patients to do physical therapy. Also important is to talk about mental health to these patients, maybe to make sure that they're reassured that, these are self-limiting things. Sometimes it may take a little longer, but it will not cause great mortality. So don't worry about it. And monitoring for complications in the high-risk groups that we talked about. In terms of antivirals in research, there are multiple antivirals which are being studied now. These are basically acting at various points in the life cycle of chikungunya. You remember favipiravir, which was used for COVID-19, is also being tested in chikungunya. So there are multiple repurposed and new drugs which are potentially being tested in various phases of clinical trials, but these are far away from availability in practice. As well as monoclonal antibodies are being tested for management of chikungunya, just as we had monoclonal antibodies in COVID-19. When do you want to hospitalize a patient for chikungunya? If the patient you are monitoring has hemodynamic instability, if the pain is not controlled, patient has severe arthritis by level 1, level 2 analgesics, if there are signs of bleeding, if there are comorbidities and those are getting decompensated. So most of the times the complications in chikungunya is because of the decompensation of the underlying comorbidity. So somebody with the liver disease develops a decompensation of the liver cirrhosis. Somebody with diabetes develops hyperglycemia and a hyperglycemic state, etc. So these are the indications for admission. And finally, obviously, somebody who has a range of severe complications, you need to hospitalize for supportive treatment of this patient and monitoring. In the post-acute phase, again, you go by the same things. You continue analgesia and add NSAIDs if needed. If it is refractory or if there are severe symptoms, you use steroids in the post-acute phase. The dose of steroid is very, very less. Use only 10 to 20 milligram daily for 5 days and then taper it over the next 10 days. So remember, when you use steroids for managing refractory post-acute phase disease, arthritis in chikungunya, use low-dose steroids. Very rarely individualized, you may need to use a 0.5 milligram per kilogram per day of prednisolone. But usually low-dose steroids people respond. So don't use high-dose steroids in this context. Usually don't use steroids for more than 1 month in this situation. Finally, for chronic disease, we don't know. Normally, we don't have very great evidence for what can work in this situation. But then there are two patterns. If there is a spondyloarthritis pattern And if they are not responding to your NSAIDs and steroids, you can use a TNF alpha inhibitor, but of course, with a consultation with the rheumatologist. In chronic peripheral arthritis, not responding to steroids or NSAIDs, you can try methotrexate, and there have been excellent anecdotal studies which have demonstrated excellent response to methotrexate. And alternative is sulfasalazine. Hydroxychloroquine is something which has not been found to be useful in CCD, which is refractory to NSAIDs and steroids. How long do you give it? You give it for 6 months at least till the patient's rheumatic problem is controlled, and then you can carefully monitor and remove the drugs. Finally, let me end by prevention. And of course, prevention, personal protection measures, as we all know, is important. And this is something which is very important to tell in your patient. If you diagnose a chikungunya patient in your clinic, tell them that you are in a viremic phase. So when you go home, you are potentially a reservoir of the virus for subsequent spread. So these individuals with chikungunya in the viremic phase need to have personal protection measures. So they need to wear long clothes, they need to apply insect repellents, they need to have sleep in mosquito nets, etc. So it's very important that these patients should be told that. At the same time, you should tell the relatives and the family members staying together of the patient to also follow the same. Because you will have the mosquitoes carrying the virus from one person to the other family. So that is the reason why you see maybe in your practice that multiple family members are infected with the chikungunya. And that is the reason why it's very important once you have a patient that you tell them and the family members to make sure that personal protection measures are in place. Then there is a range of environmental and vector control. I would not go into the details of this. It can be used at various levels of the evolution of the mosquito, right from eggs, larva, pupa to the adult. And finally, vaccines. Already there is one vaccine, the live attenuated vaccine, which is approved in the US. But this is predominantly for travelers to endemic areas and people who are high risk, like elderly population more than 65 years. These live attenuated vaccines have repeatedly shown in studies, both in adults as well as adolescents, to provide 98% seroprotection. So it's a very effective vaccine. But we don't know in endemic situations, like in India or Asia, Southeast Asia, or Latin America or Africa, whether this will work. A recent trial in Brazil demonstrated in adolescents that it works even in endemic situation. But we don't clearly know when to use it, which populations you should target, etc. So this is something which a space you should watch for. There are various different vaccine candidates in various clinical trials, but the live attenuated vaccine is already approved. So in summary, chikungunya disease is usually a self-limiting disease. We should remember mortality is very, very rare, less than 0.5%, 0.3%. Usually, many of these mortalities because of decompensation of the underlying comorbidity. Differentiating between chikungunya, dengue, Zika, and other tropical infections can be very challenging. What we can use it is some of the clinical features that I told you to differentiate between this, as well as using multiplex PCR in early stage of the disease to differentiate between these disease or to diagnose co-infections. Supportive care is the mainstay of treatment. Unfortunately, most patients respond to this. And ruling out in your practice now, since we had a great outbreak of chikungunya, as patients will come to you in future in about 3 months, 6 months, please get a history of chikungunya disease in individuals coming to you with chronic arthritis. And finally, vaccines are promising, but we don't know when to use and how to use it and target which population. So thank you for your attention, and I'm happy to take questions.
Yes.
Thank you, sir. Thank you so much for a very informative lecture. And we will start with the questions. We will take a few questions, sir. So if you want to drink some water, we will wait for 2 minutes.
No, I'm fine. Thank you.
Thank you. Sometimes PCR for chikungunya is negative in first 5 days and IgM after 15 days is also negative, but patient has all symptoms of chikungunya. So is it chikungunya or something else?
So more likely, if clinically you feel it is chikungunya, normally you will find self-limiting chikungunya getting recovered by 2 to 3 weeks. So normally these people will recover. It can be possible that the RT-PCR is negative, or if the IgM is negative. If your index of suspicion is high, kindly repeat the tests. That is what I have showed you in the algorithm. Repeat the test on a different sample. If you look at Indian guidelines, they suggest that you should transport the specimen in 4 degrees to the lab. And if you are storing, you have to freeze the sample and then send it. So sometimes it may be transport issues, which may be associated with this.
Yes. Mostly right side is seen affected in patients. I think it's about joint pain. So is there any study regarding this?
Right side?
Huh.
No, I have
Someone
not
has
come across. No, it's usually bilaterally symmetrical. Usually. You may have asymmetrical, but I don't see any predilection for a particular side.
Okay. What is the specificity and sensitivity in rapid card test?
Well, we don't know the performance. The claims are there. I've not seen their studies, but they can obviously have they claim sensitivity of 60 to 70%. I think specificity may be a problem. There may be a lot of false positives.
What is the pathogenesis behind black tip of nose and lips?
So usually it is because of vasculitis and necrosis. So there is infiltration of the vessels by lymphocytic. There are some biopsies done from India, from Kerala, where they showed infiltration of the vessels. But these are usually very small distal vessels, so that once the disease is taken care of by the immunity, there are collaterals and it recovers on its own.
What is the treatment in pregnant women?
There is no difference in terms of pregnant women. Treatment, again, supportive treatment, etc., which you do it in pregnancy. Now, the only thing is during labor, if you have, in Brazil, they have tried delaying delivery by using drugs, so that the viremia phase of the woman is over by the time she goes into labor.
What is the cost of multiplex PCR?
I think there are various labs which do it, but I think it's around 2 to 3,000 commercially.
Is there single joint involvement in sometimes?
Well, you may have that, but it is very, very unlikely. So you may have all kinds of things in medicine and in chikungunya also. But that doesn't necessarily mean that is the rule. So usually you would look for patterns. If it is a single joint, if it's a large joint, if it is very severely inflamed, I would look for septic arthritis rather than chikungunya.
Okay. What investigation should be done if patient is not recovering even after 3 months before we refer him to a rheumatologist?
So if you are proven chikungunya, so you are in the acute phase, have documented chikungunya, and then if the patient has come lingering symptoms, like joint pains continuing beyond 3 months, he goes into the CCD phase, a chronic chikungunya disease. Here your IgG will be positive. Your IgM obviously will be negative by 3 months. The second thing is your inflammatory markers may be high. So your ESR and CRP may be high. The third thing is the rheumatic disease, like lab markers like RA and anti-CCP will be negative. But you may have ANA positivity in these individuals. So better is to refer to a rheumatologist who may cheese it out with all these investigations and let us know whether it is a chikungunya or a underlying arthritis.
Yes. Are vaccines available in India?
No.
Which analgesic can we prescribe in pregnancy? I think paracetamol.
Yeah, paracetamol is the only. You should avoid NSAIDs.
Yes. Is there any oil to reduce joint pain?
I am not aware of any oil.
Okay. Many patients, many doctors have written that they have seen right side involvement more frequently. So,
Okay.
but
see, the problem with us is in our practices, we don't have primary care. patients come. So our denominators are not very great. You guys have great denominators. So it will be interesting to look at this observation. If you can document it, we
Yes,
will
because
be
most of those
interested to look.
essays
Yeah,
that-
yeah. So we can look at it. But and if it is something unique, then that can be written and published also. So
How many days does it take to reduce pain in phalangeal joints?
well, it all depends on the spectrum. So it's not necessarily joint centric. You may have these joints continuing to pain beyond 3 weeks, up to 3 months, and up beyond 3 months also. So it's not joint centric. You will predominantly see the same pattern across joints.
And what analgesics are better in long-term management of chronic chikungunya?
So in that situation, as I told you before, that many of these chronic chikungunya patients may not respond to NSAIDs. They may need DMRs. That is what we use for rheumatoid arthritis. So either methotrexate or sulfasalazine, or sometimes even hydroxychloroquine. That has to be added with brief courses of steroids. Now, NSAIDs have their own problem in terms of long-term use. Most two important things you have to monitor for is renal problems, renal toxicity, and second is cardiovascular risk as well. So you should not be using NSAIDs at very high doses for a long period of time.
Can patients exercise after recovery?
Yes, 100%. In fact, that is one of the components of physical rehabilitation which is recommended in treatment.
Is the blackened skin or nose caused by treatment?
No, it's a
No.
de novo sign of, it's called chick nose. It was in fact first described in a pandemic in Kerala, epidemic in Kerala.
So can you please elaborate about rash pattern in chikungunya, dengue, and Zika?
Yeah, so in it's very difficult to differentiate between these rashes. Usually we have morbilliform rashes. Rash is more commonly associated with pruritus in Zika. While, for example, in dengue, you will have more bleeding kind of purpuras, etc., which you may see. And in chikungunya, you may have a morbilliform rash. But usually the association with other symptoms like bleeding in dengue or arthralgia in chikungunya is something which will help you differentiate in addition between these rashes.
Is bilateral pedal edema also associated with chikungunya?
Yes, so soft tissue edema is quite common in chikungunya, acute
What is
chikungunya as well.
What is the dose of methotrexate in chikungunya, and how long should we use it?
Yeah, so the dose of methotrexate is same as has been tried in RA. So you usually use 7.5 milligram to 15 milligram per week along with folinic acid. How long you use it is basically based on response. So you monitor for response. Most patients would usually require about 6 months of treatment and stabilization of the disease. So even if patient responds, you need to make sure that the disease is stabilized before you discontinue methotrexate.
Is there any role of chloroquine phosphate or HCQ in chikungunya?
It is one of the DMRs which has been tried out in chikungunya CCD as well. But the results of chloroquine has not been exceptional when you compare it with, say, methotrexate or sulfasalazine.
So what is the difference in peripheral smear of dengue and chikungunya?
Peripheral smear in dengue, you would say, I'm not sure, you would say thrombocytopenia. I mean, that's all. I don't know. Honestly, I don't know.
Is there any role of doxycycline?
No role of doxycycline.
Patient does not get relief in pedal edema even after giving Lasix. So what can be the cause?
Well, this is a soft tissue edema, which is not necessarily because of fluid retention. It is basically because of leakage of the intracellular to extracellular fluid. So diuretics is not really recommended unless and until the patient in heart failure, etc. So in that situation, we would not recommend diuretics. It is self-limiting. It will go off on its own.
And last question, sir. Doctor has written, I saw one lady patient who is chikungunya positive. She had blisters like rashes under her breast. So is that related to chikungunya?
Yeah, so you may have very rarely desquamation also, like toxic epidermal necrolysis kind of a presentation. These are very, very unusual presentations, which have been described in literature. And just as the striae rash that I showed you, where you can get rash on the striae, pregnancy striae, etc., you can get it under the breast also.
And there is one more question, sir. For how many days morning stiffness remains?
So again, it is the same during the phases. So in the acute phase, up to 3 weeks, you can have morning stiffness. You will recover the morning stiffness in the acute phase most of the times. In 50% of the times, you may progress to a CCD where morning stiffness can last for the longest chikungunya disease, arthritis, which has been described in literature, is 13 years.
That's true.
This is an anecdotal report, but most people would have this from 12 months to 18 months. So it's unfortunate, but this is something which is very, very known. Almost 50% people will have it.
And many doctors are using injection dipomedrol. So
Where?
we
For
chikungunya.
in the joints or where?
Mm,
Depomedrol means, I think it's a inject local steroid. I'm not sure. So in chikungunya, injectable steroids are not recommended in the joints for a simple reason that these are multiple joints. You can't inject all joints.
No, intramuscular that doctor has specified.
Steroids are not recommended for acute management.
Thank you so much for answering all the questions, sir. Now I request Dr. Prakash Mahajan, sir, to summarize the session and give vote of thanks. Dr. Mahajan, sir. Dr. Rupa?
Yeah. Sir, I really feel proud to say total 199 people joined on the YouTube, along with we covering 100 doctors on the Zoom link. So that says it, that is the automatic proof that how important this lecture is for the general practitioner. And it is learning from you along with the scientific base and the backup of research along with the other countries face to the illness is very important. So it is very important learning for all of us. I request Mahajan sir to take over. Prakash Mahajan sir.
Yes. I'm audible. I think I got some disturbance in the internet.
So you are audible.
Okay. So at the end of the lecture, I think I'll just deviate from the protocol. You usually thank the speaker first, but I'm going to thank the audience first this time.
Mahajan, sir, we
In fact,
can't hear.
Dr. Pujari once said that I'm not able to answer this question. And that must be a feat of some kind. So I thank all those audience for joining us repeatedly again and again for all the lectures and giving us a very good response. Secondly, I want to thank the Mukta team, Dr. Rupa, Dr. Gayatri, then Dr.
I think current internet issue as well. Dr. Gayatri, should we continue?
Yes, because
So, Pujari sir, thank you once again. And thanks to all the participants. It is very encouraging that those numbers, which are very attractive for us, which these numbers are the one which keeps us motivating. Whatever lectures we are organizing, that lectures are useful. Many of the times nowadays we see in-person lectureला सुद्धा तेवढे डॉक्टर्स कधी कधी प्रेझेंट नसतात आणि ॲज Society for Foundation we feel so complete, so satisfactory with the experiences की जेव्हा आपण सेशन प्लॅन करत आहोत आणि 300-350 डॉक्टर्स आपल्या सेशनला येत आहेत, so it's a unspoken gift or return to our investment in learning from special guests and teachers like Dr. Sanjay Pujari. So thank you once again. Thanks to all of us. Thank you. Have a great evening. We'll end the meeting.